Good evening, everybody, and welcome to today's sessions on for the BRCA and Hereditary Cancer Workshop. Looking at psychological challenges when you live with a hereditary cancer risk. It is my great pleasure to introduce Dr. Larry Kaplan, Dr. Mariella Loriola, and Dr. Neha Goyal, who will all introduce themselves in just a minute. I also like to give special thanks to Lou Romanos, Renard, for making the logistics work for our IT support, and Danielle Sipes, who has worked on the flyer. I think our nurse practitioner Bess will be um, on the panel, as always, has very good comments and provides a lot of helpful suggestion. The agenda is we have brief introduction, and then we talk about with panel discussion. All participants have an opportunity to write in questions. We try to field as many questions as we can live. Some of them we will answer. We then have another Q&A that's a little bit later. So with this, can I have maybe Dr. Larry Kaplan introduce yourself?
Yes, thank you, and thank you for including me here. Um, it's a wonderful opportunity to talk about what we do in terms of working with patients in the Cancer Center. I am referred to as a consultation liaison psychiatrist, so that means I work more in the medical field. I work in the medical hospital. I work in the Cancer Center as well, and we receive referrals from various oncologists in our Cancer Center and from outside cancer centers as well. So we deal with a lot of the psychological stress, treatment effects, those kinds of things as well. So that we have a pretty wide bandwidth in terms of some of the symptoms we will treat related to getting the various diagnoses, having concerns about, inherited cancers as well. So um, that is our role basically.
Thank you. Dr. Goyal.
Yeah, thank you again for having me. My name is Dr. Neha Goyal. I am a psychologist within what is called the Psycho-oncology department at the UCSF Cancer Center. So we see within our clinic, we see patients who either have a cancer diagnosis or again have a high risk of developing cancer, whether that's due to a genetic mutation or high family risk. And work with patients on a time-limited basis to sort of learn coping skills for managing the anxiety and the stress that may come up related to that particular diagnosis. And we also run a couple of groups that can help with learning different skills for managing the anxiety and stress that come up as well. So that is my role, and I'm glad to be here.
Dr. Mariella Loriola.
Thank you. Hello, everyone. Thank you for being here. My name is Dr. Mariella. I'm a licensed psychologist in California, and I'm a trauma expert and specialist. I have a private practice in Cupertino, and we work with clients experiencing trauma of many different types, a lot of relational trauma, medical trauma. And on the side, I also volunteer for the Bay Area Cancer Connection, which supports women overcoming breast cancer and ovarian cancer, um, in any stage of their diagnosis. So, yeah, thank you so much.
So before we start taking questions from the panel, I like to share a little bit of what I see with working with the patient population, and particularly the fact that that was also my experience when I was first learned about that I had a mutation. It's like when you learn that you have a mutation, your mind just goes, "I'm gonna have cancer. It's gonna happen tomorrow." And I think so. Like, how and it's very challenging to put in perspective that you have a risk for cancer, that you don't have cancer, because your mind doesn't actually deal as well with this. Can I ask the three of you to weigh in on, like, are there any good coping mechanisms? How do you deal with how 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 does psychology deal with the, if you will, the phantom fears or the untangible fears of getting something rather than having a diagnosis of cancer? Maybe I start with you, Dr. Kaplan.
Yeah, those are definitely fears that come up, and I think we're kind of primed to have this response, this fear response, and it can, really take its toll in terms of affecting us in many different ways. We start to think about, what are the downstreams effect, how this would affect my vocation, how will this affect my relationships, how will this affect more of the physiological issues as well, of increased anxiety, mood symptoms, some of the treatments and what those might induce, and some of those various symptoms as well, sleep, all of these things. So I think it's really something that we tend to adjust to, but I think, on balance, when we first, hear of this, we tend to get more into what what we call almost fight or flight response, which is a natural part of our existence and our makeup. And so I think getting the most support that you can navigating through that early on is very important as well.
Is there more science around, like, why this is a natural reaction? Why do people have that? It's like, there's something good about having all these fears?
Well, I mean, for survival, if you go back many thousands of years in our evolution, this is what protective for us, to go in this sort of response, and that, it was for survival, for going back to even hunting or being hunted, and accept that the problem is that we have an overactive response to this, and then that causes all the downstream effects, which we call the HP axis or hypothalamic pituitary reaction, that can cause all kinds of other hormonal changes in your body, and it's very physiological in that way. So there's definitely various types of therapies that I believe the psychologist here can address, as well as we do have medications as well to help sort of dampen down that response and really improve quality of life to the best, that we can, for someone having to deal with this.
But before we go on, so would it be fair to say this is sort of like a physiological response that happens, and that's not necessarily with just people just super anxious, but this is an expected response that your body and your body's hormone produce, is not all just in your head?
Exactly. It's very physiological. I think it's always physiological. I mean, there has been a lot of study. There's a lot of evidence-based work in terms of this. It's been, especially in the last, say, 20 years, even 10 years as well, where we've learned a lot through even functional MRI imaging, various measurements of cortisol, and all kinds of other things with our autonomic nervous system, the balance between what's called the parasympathetic and sympathetic response in our nervous system. So yes, I think it's very physiological, and I think that helps a lot with some of the stigma attached when we start to have some of those symptoms that evolves around mental health and that sort of thing. So I think it's a good way to think about it, and as we might any other physiological condition or health condition.
And then I think Dr. Goyal is like, did I get your name right now, Goyal? Like, I think what you learn as a physician, when you as a physician become a patient, when someone says don't worry, you'll be fine, that just doesn't help at all, right? It's like how would you recommend that people or loved one deal with this, like in avoiding to say don't worry when you realize that your spouse or loved one can't sleep, can't eat, is totally nervous all the time? Do you have any advice for relatives or also for the person in that situation?
I think there's a lot to be said about just listening, honestly, right? So this approach of just active listening and really kind of as a family member or someone that's surrounding someone who's dealing with a stressor like this, of am I trying to fix this for them or am I here to just be present? Because I think we can underestimate how much just simply sitting and being with somebody and even acknowledging and validating how they're feeling and doing can be so powerful. Because when we do question, or you're told don't worry, then we start to question, am I worrying about something I shouldn't? Are my feelings valid? Like, is this a normal response to the situation? Whereas, what Dr. Kaplan just sort of voices, it is a normal response, right? When you have gotten this diagnosis, to feel anxiety, to feel this, just worry around, do I have cancer? Or when is it going to come? Or, those thoughts that are coming up. And so I think initially what can be most helpful is listening, right? And not trying to fix it and say, here's the solution, here's what you can do about it. Maybe there's a time and a place for that a little later on when you've had some time to process and are maybe looking for feedback on how do I now deal with this? What are my next steps? But I think in the initial phase, that just listening and validating is kind of the most important for the medical teams as well. To your point, the physicians who are sharing this news with patients, or the counselors or the genetic counselors. And then that goes to the family members and the loved ones around this person as well.
Thank you, Dr. Loriola. What's your advice for loved ones in dealing with the significant traumatic response that you see in our patients or survivors?
Yes, absolutely. So you've all touched upon so many important things. So let me try to answer in my way as well. So first of all, yes, this is a very normal physiological response to be anxious. We call it anxiety. I call it trauma. This is a trauma response to a traumatic event. You receive that diagnosis, which is, of course, life-threatening. So this is very stressful. You didn't want this. It's out of your control. So, of course, the anxiety that comes with it, we call it hyperarousal in trauma words. It's very expected and normal. Not only that, even the depression side of it, like there is the hyperarousal, the hypoarousal that come with it. It's all very physiological and normal. It's our nervous system response to threat. You are receiving a life-threatening diagnosis. Your response is very normal and healthy in a way. And of course, there are ways to help with that response. For answering the question that Dr. Munster asked about, how can the family member support the person that received the diagnosis? I echo Dr. Goyal on what she said. Just listen. Sometimes that's all that the patient really needs. But also I also always tell my clients, my family members, ask. First of all, empathize, right? Empathy. I'm so sorry. This is happening to you. I can see you are very anxious. How can I support you? What can I do for you? Is there anything you need from me? Sometimes it might be just listening to the stress and the anxiety. Sometimes it could be, let's go on a walk. I don't want to talk about it. Let's just go on a walk. Sometimes it could be, let's go get ice cream. Whatever there is, don't try to fix it. Yes, I agree with Dr. Goyal. Don't try to say there is so much that you could do now. Like that's so invalidating, right? So let's try to help the person cope with what's happening for them in that moment by just asking and respecting the answer. If they say, I don't want to talk about it, we respect that. We for sure can ask, can share our concern for our loved one. Hey, I can see you're very anxious, you're not eating, you're not sleeping. what do you think about reaching out for support? Maybe we should get some professional help on this. What do you think? I'm happy to come with you. I'm happy to help with finding someone if you want me to. What do you think? I'm very concerned about your well-being. That's also okay to say, but again, trying to respect the autonomy of the person, like always trying to be um, open to what is coming up for them. After all, it's about them. And of course, the parents or the loved one needs support too. This is vicarious trauma for them. If they're the loved ones, if they are the partner, I mean, they're going to be impacted by this too. They need support as well as, caregivers possibly. So of course, I would recommend for them to seek help and to take care of themselves as well, because this is vicarious trauma, we call it. They vicariously experience it, even though it's not happening to them. So, yeah.
And I would add to that, to not be able, as the person dealing with the diagnosis, to be okay with asking for that help. I think what I find is a lot of people struggle with asking for what they need or asking for help from their loved ones. And I find that often our loved ones or our caregivers are looking for that. They're looking for ways that they can support you and are really, I think, appreciate when we can give them something maybe specific that they can do to help us. And sometimes you may not know, and that's okay. But if you do have an idea and just feel like, oh, it's going to be so burdensome for me to ask that, if that's sort of a thought process, that I think it's important that we do ask and can be very meaningful. So not only having our loved one ask us what we need, but also being willing to share what it is that you need is also important.
Yeah, I think that's very important. I come across that quite a bit where patients will tell me, oh, my relationships have changed with my friends and that sort of thing. And so because the friends don't know how to support the individual, and vice versa, the patient doesn't know how to ask. And so there is this abyss that can come about, and learning how to bridge that is very, very important. And also the other point I want to address, you brought up, Dr. L'Oreal, is autonomy. So, once you're under all this medical care and you're going through all this genetic testing, there's a sense of loss of autonomy. So it is important to uphold that autonomy or give some sense of agency by just allowing the patient to elaborate on what they need, what they want at that point in time, and not imposing values on them in any way.
Dr. Munster, you're on. Yeah.
I also remembered when I first learned learned about my mutation, I felt extremely lonely. How and people feel like their normalcy is just gone, and now there's worry everywhere, and and people struggle with that loneliness and that uncertainty. Is what is that normal? Is that what you hear from people? Or and do you have an explanation where the loneliness is coming from?
Well, my understanding is sort of relating to what I was just talking about. There can be the sense of isolation because it's like no one, my friends, maybe we're used to doing all these social activities together all the time, and that's what we talked about. And now I don't think anybody can relate to this, and feeling very isolated that it's only me that has this condition, and I don't want to burden other people with it, and I don't know how I will talk about it. It's all of this. I think it's because there is a sense of your relationships. It may have changed in some way. It does to be aware of that, and it is important. And how do we bridge that? How do we adjust to that? Maybe we do need, just being able to ask for having, maybe some more time together, whether it's with yourself or with your family as well, but also trying to work through the isolation and time. But yes, I think it is very isolating and feeling a sense of loneliness that can come about. I think it's very natural for that to happen as well. We sort of retreat into ourselves at that point.
Dr. Lori, sorry, go ahead, Dr. Goyal.
Well, I was going to say, I see this with many medical sort of experiences or traumas where there is this sense of isolation or this sense of not feeling connected to other people. And to Dr. Loriola's point, I mean, that's actually a trauma response as well, is to kind of feel disconnected from others around us. But I also think it speaks to, and I will say this is where social media has been a little bit beneficial, is like there is more information out there when you kind of Google something that, again, there's the cons, but there also is this sense of like, okay, I'm not the only one dealing with this. And this is why I love running groups, is that like when we can come together with other people who have a shared experience, there's something so powerful about that. And I think, being part of a group, whether it's any of the, organizations out there that offer these types of supports, where you can be with other people who are dealing with something similar, it really can be super helpful in that sense of that isolation. But again, I think, another not unexpected response when you're dealing with a new diagnosis of honestly any kind of medical diagnosis is my experience in working with different types of patients. Yeah.
So we have a lot of support group like Force and Bright Pink and others, but do you have specific support groups for the more psychological part that you could
unfortunately,
refer
not within
patients to?
our own clinic. It's something we've talked about, and if there's interest, we might, consider making that a thing. But we do have we have other groups that sort of teach just general coping skills that I think can be applied to anyone in any real situation, and that can include that, but not one that's specifically targeted towards not within our own clinic, but it's something we're open to, are interested. Yeah.
And Dr. Loriola, you specialize in trauma, and you have also a focus on EMDR. Would you give us a little bit of a backdrop on what your practice is and who you are and what EMDR is like?
Yes, absolutely. So my practice is I'm a trauma therapist. Like most of my clients come to me. I think I've done a good job, with identifying myself on my website, because the clients I usually receive are trauma clients. People with more generic, concerns don't usually contact me. And that's what I do every day. I work with trauma every day, different shapes, usually most likely relationship trauma, because I also work with couples. And even with couples, there is a lot of relationship struggles, relationship trauma, as well as, past childhood trauma. So that's what I really do. And how trauma, Dr. Munster, would you like me to talk about how EMDR could help with this specific trauma of receiving a diagnosis? Okay, so how I see this really helpful. So I volunteer for the Bay Area Cancer Connection, which is another amazing resource for people that are looking for psychological support group, where people just go there to talk a little bit about what's happening to them. They have different support groups or different groups that support in different ways clients at different stages of the journey, and it's completely for free. So it's wonderful resource. And I volunteer and I support. I give just free support, psychological support to clients. They can be at any stage, and it's so beneficial sometimes to even do just a couple of the techniques that I use with my clients ongoing with them. Of course, we cannot do EMDR therapy with them because they're usually on the phone, not even the video call, because they are not tech savvy sometimes. And we're like, okay, let's do it on the phone. And I can still do some reprocessing technique. So how EMDR is a technique that helps your brain move past the stress. Trauma is a stressful situation. What's traumatic? Trauma is a synonym of stress, So when something is very stressful, we call it traumatic, because our system has a hard time to cope with it. So our nervous system needs some help to get past it. And of course, a diagnosis like this, it's very, very challenging. It's life-threatening, and the nervous system gets stuck in this trauma response, this survival response. And what EMDR does, EMDR stands for eye movement, desensitization, and reprocessing. What EMDR does is that helps the person, the brain, the nervous system go from overwhelmed, kind of like emotional brain, the more, what I call the more antique part of the brain, the limbic system, we call it, to the more, cognitive, the more reasoning brain, which of course we cannot reach in a state of stress. Imagine of having to do an exam when you're stressed out and are anxious. You're not going to be able to perform at all because there is too much emotion. So what EMDR does is helping you to reduce the stress, reduce the emotional charge connected to what's happening to you, so you can get to more adaptive thinking. The diagnosis is not going to change, but you're going to have more clarity on the steps to take to be in control. We cannot change the diagnosis, but we can change how you cope with it. What do you want to do? What steps do you want to take? But without that emotional kind of like calm, you cannot really do any of it, because you're going to be always overwhelmed, always set off. And that's what EMDR does. It helps the brain to calm down, the nervous system to regulate again, so that you can now think about, okay, what do I do next? So this is how EMDR can really be helpful for in cases like this or any medical trauma, really. But this, of course, it can really help.
Thank you. So before I go with more question, I'm going to quickly introduce also Beth Lynn, who is our main nurse practitioner for the program, soon to be joined by Veronica Firm and Vaughn, who is also partly working with us. So Beth sees a lot of our patients, and I'm sure, Beth, you can speak to how stressful such a diagnosis and such a mutation can be. But I think a major stressor comes from this, what we call the scan anxiety. A lot of patients have scans and tests and imaging ordered all the time. And the one thing I really vividly learned as a physician after having been a patient is how important timing is. So in other words, if you had an MRI and the results don't come back for 3 days, you don't worry yourself completely into destruction. If someone tells you that you should hear about it the next day, it's a little bit different. So I think what doctors often do very poorly is we don't communicate well, that it may take 48 hours for the pathology to come back. So I think that's the thing, is like when you talk to your doctor, just ask when the results are expected to come back. When do you expect to hear from us? But in terms of other coping mechanism, Dr. Goyal or Dr. Kaplan, is there anything that you can deal with scan anxiety or like a?
So I mean, this is so common. It's like totally a very normal and understandable response to this upcoming sort of test that's going to tell you, do I have cancer or not? Or, some other test that obviously is understandably going to make you anxious. And again, that's protective of us, right? It's sort of our survival instinct to it helps us to sort of like prepare and think about and plan and do all of these things. But what I will tell people is my favorite strategy for dealing with scan anxiety is distraction. So I don't endorse distraction as sort of a long-term strategy for dealing with anxiety or dealing with sort of other emotional challenges, trauma, but for something that is time constricted and has a clear end date and a clear sort of result pending. Like I tell people that the week up to your scan and even the time that you're waiting, if you can make plans and like make plans with friends, do things that you enjoy, because all you're doing is waiting, right? So you can either wait and sort of like and wait with your brain and let it sort of do what it wants to do, or you can choose to wait while distracted and doing something you might really enjoy. And so as a strategy for dealing with scan anxiety, I say, my favorite thing is distraction. distraction. But I always give the caveat that that is not a great strategy for dealing with all types of emotional challenges that are arising. But in this instance, I'm a big fan of that.
Dr. Kaplan, a little bit more deeper. So from what I can tell from the practice, the first year of the diagnosis can be really, really troubling and very traumatizing. And there is a little bit of getting used to the diagnosis in later years. If someone really struggles, what are other medication intervention that could be considered to help people just over a certain time? When do you think medications are indicated?
Well, what we try to do in the Cancer Center is oftentimes we'll have patients referred to our, we work with Dr. Goyal and her colleagues as well. And sometimes the patients will be working with them with various strategies and that sort of thing to deal with, the diagnosis, scan anxiety, all that kind of thing. But then as Dr. Goyal and her colleagues get to know the patient, they realize that maybe that's not just enough. And we always think about both strategies, more of the behavioral strategies, and sometimes medications, doing them both together in unison rather than just, I always like the behavioral approaches first, but I think it'd be very helpful for one's quality of life. Like usually, what we call this is more of an adjustment disorder. If we have to give it a name, if we have to give diagnosis with maybe anxious features or, some mood symptoms or whatnot, just because of the diagnosis, but also maybe from some of the treatment too, as well. And so there are medications that we can think about. And we generally like to be very conservative. We think about sleep, we think about anxiety and mood, and there are medications that we can think about that can be very helpful, that can be taken as needed, or do they need to be scheduled, and are they ones that are pretty benign, and then they can be discontinued once we've gone through this sort of more challenging patch. There definitely are some very good medication strategies that we think about that can be very, very helpful and not addicting or anything like that, and not difficult to discontinue as well. Because those are some of the concerns that always come to us as well.
Yeah, and I think I really want participants to hear that. I think when people hear about they need to go on a medication for anxiety and distress, people think that's for the rest of their lives. But I think we've been very, very successful getting patients off, right, and having a transient medication support. So when is the time for people to get off? Can you speak a little bit to this?
Yeah. I mean, it's a little bit different, when someone has a mental health history, and they say they've had long-standing depression or something like that. Sometimes, it's lifelong if that medication is really supporting you throughout your life and you're very functional and whatnot. But in terms of what we call more of an adjustment reaction that we're talking about, I would say this, in that once, it settles in, when people get sort of you get all the information back, the scans, the pathology, you have treatment regimen in place, whether it's going to be a short-term treatment, or depending if it's more long-term, then we sort of decide with that and see if just the initial response, be it a trauma response or whatnot, if that starts to subside over time, it might be, I think you have to relegate yourself to a minimum, let's just put it this way, of 2 months, on any medication to get to what we call the steady state and that sort of thing. So I would say maybe it's 2 months, maybe it's 6 months, maybe it's a year, just somewhere within that time frame. And then, we re-examine this all the time and see, is there a need to continue on? Because our standard is we just like to use the least amount of medication for the least amount of time, and that's basically how we generally deal with some of the conditions that result from someone who gets this diagnosis as well.
Thank you for this, Dr. Goyal. You talked a little about groups versus individual therapy. Do you have recommendations on who is best helped with what, and or how participants even can seek out group therapy sessions? I think a lot of our patients actually don't know about that.
Sorry, trying to unmute myself. Yeah, so I think, most patients would benefit from individual therapy. I think that that can be helpful. But I think that for those who are kind of seeking connection to other people, maybe those people who are feeling isolated or feeling like others don't understand what they're going through, I have found in my experience that, and actually I just finished up a group today where everyone was sharing how powerful it was to be connected with others who had a similar diagnosis to what they were dealing with. And so so for anyone who's sort of feeling isolated, feeling like they want to connect with others on what they're experiencing, I think it can be really powerful to be in a group setting. UCSF offers a number of different types of group. Again, I don't think there's any specifically targeted towards those who have a BRCA gene or the hereditary cancer, but there are sort of through the Osher Center recently, which is our integrative medicine center. They've really been expanding the number of group offerings that they have. So they're called group medical visits, and you can look them up online if you type in Osher Center group medical visit. And so some of them are targeted towards sort of teaching different behavioral and integrative strategies. So there's some beautiful ones on like nature therapy or Qigong, for example, which again are things we know are really helpful for navigating any really kind of medical or emotional things. But we also have sort of groups through our Psycho-oncology program that are like what I called our skills coping group. So it's really a combination of, you come in, you learn some skills, but in that process, we also have discussion and we also share experiences and, allow people to connect when they are dealing with something difficult. But I will be honest, I'm less familiar other than some of the support groups that might be through like Force and other organizations that are specifically targeted towards this population.
Survivors. Dr. Lariola, I was very intrigued with your ability of reaching multiple trauma victims or trauma groups with the EMDR and other coping mechanism. Can you speak a little bit to that?
You mean group interventions?
Yeah.
Yes. So it's nice. Recently, I mean, this has been present for a while now, but there have been some interventions have been developed to help larger communities at once, especially in humanitarian settings, and they are still reprocessing techniques, and they work amazingly. And we have started to do that with our Bay Area Cancer Connections. We have workshops twice a year in which we administer these interventions. However, since it's considered therapy, it should be only with people residing in California, because for example, I'm running the group, I'm running the workshop, and that's run so I can only help people in California because of my licensure status. But basically, there are different interventions that can help reduce the stress, and we could do it online. We can help 50 people, 60 people at once, and these techniques really, really work very well. One of them is called, the most used one is actually called the assist technique, and again, you could do it with emotional support team with as many as 100 people at once, like maybe more, as long as you have the support system for supporting the clients. It's a very beautiful. I don't know how much in detail would like me to go, Dr. Munster, but there are techniques that can be done in groups, yes, to reduce the stress, and they're still considered reprocessing.
Thank you. That is very helpful, and I think Dr. Goyal and Dr. Kaplan, maybe that's something what we should try to offer even to our patients. I think the previvors and their anxieties is still very under-recognized. In part of it's under-recognized because people don't actually have cancer, they have a risk of cancer. And I think it's often not recognized how much stress this can actually cause. And I think I'd like to bring in Bess here for a second. Bess, what is the major traumas and anxieties that you see in clinic from our patient that most people are not as familiar with?
I think, well, there's a number of categories. One problem that I see a lot is we have so many young patients, 24, 25-year-olds, that are having to think about cancer. And it's not something that usually a person that age thinks about. And their peer group, when they talk to them, people don't really understand because they say, well, you don't have cancer, right? No, I don't have cancer, but I have this risk of cancer. But you don't have cancer. So I had a woman today, young woman, she said, I feel like I'm walking around with a time bomb. I know I have it, but nobody else sees it. And so I don't get, if I had cancer, people would have sympathy for me, but because I don't have a disease, I have the potential of a disease, I don't get the same kind of support that other people do.
So that is very helpful. So for the participants, if you have questions, please put it in the Q&A, not in the chat. I think we'll try to get to your questions, but if you could put it in the Q&A. A couple of questions is how do you recommend we deal with the stress of removing healthy tissue? Like a lot of our participants and variant carrier are asked or recommended to remove their breasts, remove their ovaries, remove other organs. Like, is there any recommendation how you prepare yourself for surgery? Maybe Dr. Kaplan? I know this is it's not a straightforward question and everyone is probably different, but do you have things that people could consider?
Okay, well, so considering for prophylactic surgery, basically.
Yeah, how does as best that how does a 25-year-old young woman prepare herself for risk-reducing mastectomy?
Yeah, I think that's very hard, with the body image changes, the thoughts of, maintaining fertility, all these other issues have come up. I have certainly encountered patients with that before them. And I think also it's important to think about if there might be some outside external pressures as well, and being of, maybe for a woman, childbearing age. And I think it's really difficult in that way. And I don't know. My thought around that is it's very important, I think, to have a lot of open lines of communication with be it a partner, a spouse, other family, all these expectations that are put on young women as well, whether it's internal, external, trying to identify that, and it's very, very challenging. Because I've had cases where there was a woman I had in clinic who she definitely, her and her sister both had the BRCA mutations, and she had married her partner. He was Mormon. His family was Mormon. They had expectation for all these children and that sort of thing, and that was putting a lot of pressure on her as well. So I do think family therapy, couples therapy, all that's really, really important to really open up the communication there. So I think those are very, very hard decisions to make as well. Yeah, I would be interested in others' thoughts on this.
Dr. Lauriella?
Yes, this is a tough one. So I want to say my biggest thing around surgery right, would be inviting the client to gather as much information as possible on what they can expect after, like what can help maybe for the surgery, so they can mentally prepare, because if it's unknown, it's going to be even more traumatic, right? If you don't know what you're going to, for how long you're going to be recovering, the pain that might come, because I've in my little experience, I've had some surgeries, and sometimes I was not prepared at all about for the post-op, right? Like I was like, maybe even just stupid things, like tonsils. No one told me I couldn't eat for a week. This was many years ago, but that's horrible. You want to know, like, okay, what's going to happen? Otherwise, it becomes traumatic, and it happens all of the sudden. So I want to say definitely gathering information, offering the information to the client, to the patient about what's going to happen. Being kind to yourself, giving yourself time to recover, because sometimes maybe people start working again after a week or a few days, and maybe giving yourself that self-compassion to take the time to really recover fully. Your body might take weeks to recover from such a surgery, so be mindful of that. Asking for medical leave if you're working or if you're studying, right? Like same thing, so I mean, all of those precautions that might help you recover better, what do you need during the recovery phase? Do you need to talk to someone? What do you need before the surgery? Do you need to talk to someone because you're experiencing anxiety around it, and maybe you want to explore, your feelings? Maybe just talking about it with someone that really understands what's going on for you. I think those are all great ways to cope with what the post-op, the operation itself, and the preparation phase.
Thank you. Dr. Goyal?
I feel like my initial response was like, you're never going to be prepared, right? Like you're never going to be fully prepared for going through that experience. And so I think, so that I'll just say that was my sort of initial sort of response to that. But I echo what Dr. Kaplan and Loyola were saying, around the practical aspects, like as much as we're able to make sure we have that time off, or that we have the support resources available for us pre and post surgery. And, and I think really getting to a space where you're never going to feel, or rarely are you going to feel 100% certain about this decision, because as humans, we're really not great at assessing risk, and to ask ourselves to do something like a prophylactic surgery with this could help, but I'll never fully know if it helped. It's really messes with your mind, as I find, as I support people as they're trying to make a decision. Do I do this surgery? When do I do this surgery, right? Because it's not urgent per se, but it is a decision that has to be made. And I think that sort of, whereas somebody who has the cancer diagnosis and it's present and you're like, we have to get this out, it's a very clear decision, or even then it's not always 100% clear, but it's a lot clearer than somebody who's dealing with these sort of like abstract ideas of like, I have this, as you mentioned before, like I have this thing, but I don't necessarily have cancer. And now I'm being asked to sort of remove these parts of my body that maybe are really a strong sense of your own identity, right? Of whether that's identifying as female or your sense of self. And so to be asked to do something like that, I think it's important to take that time to process that decision and talk about it with a trusted loved one or a professional in terms of what makes sense for you and is guided by your own values in making that decision. But I go back to like, you're never going to be fully prepared. I don't think there's anything that you can do to fully prepare yourself. And that's normal. And that's okay. I think being able to just acknowledge that, right? To say, I'm not going to be prepared and I'm just going to do the best that I can to make this decision with the information that I have, and move forward with the practical aspects of how I can get support.
Well, that's actually really, really helpful. I think just the notion that no one is ever prepared, and there's really not the stress will likely not gonna go away, and you need to be as surrounded as possible by loved one and support. But I do want to stress something that all of you mentioned is like when you're facing life-changing surgeries or like intervention that are really hard to do, this is not the time to beat up on you. And I think a lot of us spend a lot of time trying to be better, being a better spouse, a better teacher, a better mom, a better this, a better that. This is probably the time to really be kind to yourself and be okay with not being perfect. And I remember as I was going through all the surgery, someone told me be kind to yourself, and I didn't quite understand the concept, what being kind to yourself actually means, because that's not how we often raised. But this is really the new term is say self-care, but I think being kind to yourself is actually probably a much better term than self-care. And it's just accepting is a very hard time. Have your surroundings be with you and understand that your partners are not perfect. It's a lot on the partners. They worry for you. They don't know how to talk to you. And I think in communications, I think Dr. Loriola, you mentioned this, like the partners may always ask you the wrong questions. And they may need help from you to guide the question. What is a good question for you? What is not? It's like the concept that you may have to guide the conversation is probably new to many folks. And then I think it's really important for folks to hear that it's quite okay to seek professional help, because partners may not always be able to handle all of this. And it's really great to go and complain to someone else than to the partners. So I think please help me really get the points across that seeking professional help is important. It's really often necessary, and this is totally justified. The best is a couple of questions that we as doctors don't make these recommendations for folks seeking help. Can you speak to this a little bit? What is it that we can do from our practice side to offer more help to folks? You're mute. Beth?
Oh, sorry, me?
Yeah, you.
Apologize. What I hear from patients a lot is that they have difficulty with making decisions, the big decisions about what to do and when to do it and who to tell. And they're uncomfortable with making those decisions without all the information. And this is making decisions about a mastectomy or having ovaries removed or doing any of these types of interventions, people will never have all of the information. So they have to get somehow comfortable with making a decision without really knowing. And so I encourage them to talk to healthcare providers who can give them more information. We send a lot of people to surgeons to talk about, so what does the surgery look like and what does the recovery look like? And I explained to them, I said, even if you're not ready to get surgery now, go talk to somebody so you understand what your options are and kind of what it's going to look like, so you can plan next year to have your mother-in-law come to help you with your kids, or you can plan to do it over your summer vacation because you know you're going to have enough time to take care of yourself. So to the extent that I can, not as a surgeon, not as an oncologist, I try to help people with that information. But when they go to see the doctors, the important thing is to give them more information so that they can get comfortable around those decisions.
Okay. So taking this around a little bit as like questions for you, the professional, what do we recommend to patients who just cannot make a decision? What advice do we have for people who just don't want to make a wrong decision and therefore just don't decide for anything? How do you deal with this? Dr. Kaplan, do you have a good suggestion how to help someone who just cannot decide?
Yes, ambivalence is human nature and very challenging to deal with, because there's always going to be this thought of is this the right or the wrong decision? Is this the right time for it? There's going to be, everyone's different. There's some people they're very statistically oriented. They're going to, be very focused on talking to their doctor about what is the rate of the recurrence or the occurrence, I should say, of this particular type of cancer and those kinds of things. So I think more of, and it takes time and reflection and information, but maybe more of a cognitive behavioral strategy that you have to use in that, and just sort of, the pros and the cons and that sort of thing, and listen out and maybe have more of a visual representation of that, and it's something that you can work with. I'm sure, Dr. Goyal and Dr. Laurier are more expert in that than I am, but more of that type of approach. And, because I think otherwise, if we're in our heads just thinking about it, we can have decision paralysis almost in that way. So I think more of a cognitive approach in that way can be more helpful in dealing with that ambivalence.
Dr. Goyal, how do you deal with ambivalence?
Yeah, I would say, again, to Dr. Kaplan's point, that is a trauma response. I think when we feel overwhelmed by, we can get paralyzed, right? It's fight, or freeze. And often when we're, faced with this really difficult decision, it is normal to sort of feel so overwhelmed or paralyzed that you can't make the decision, or you feel like you can't make that decision. And so I think to Dr. Kaplan's point, there is a piece of sort of the cognitive, like, let's go through some of the, talking it out with someone who can help you sort of weigh, what information do you have? What information do you feel like you need? What's missing in order to make that decision? And is that realistic, right? That is information you will be able to get. It's the self-compassion there too, to your point earlier, Dr. Munster, like, I love the phrase, like, you can only make the best decision with the information you have at the time you're making that decision. Because again, you can make a decision and then, you get more facts afterwards, because now you've been through the experience. But when you were making that decision, you were using the information you had at that time, and we don't know what's going to come. And so learning coping skills to deal with the uncertainty of that, I think, is really important if you're not sure. But also what I will tell people is sit with either decision for a couple of days. So if I decide to not get this surgery, like, how does that feel? Like, if I were really just going to make this decision to not do surgery, like, how does that feel in my body? Like, what's coming up for me? What am I afraid of? And then the next couple of days, sit with the decision I am going to do surgery, and like really kind of sit with that and see how that feels, what comes up for you, what are your fears, what are your anxieties. And then I think that just is informative for you to then just, you're going to have fears either way, right? And so weighing sort of which is the decision that feels more in tune again with your own values. And I think there is something about in dialectical behavior therapy, there's this concept called our wise mind, which is just sort of a fancy way to call our intuition. And we all have this. And so if we allow ourselves to kind of like sit with something, we can kind of sometimes access that wise mind, is what we call it, of where we're using our reason and our emotion mind in a way that's honoring both. And so are we doing something that's honoring that and come to that decision? But it's hard. It's really, really hard.
Dr. Lauriola, any strategy advice for dealing with ambivalence?
Well, there is not much more to say, to be honest, but I want to just echo some of the thoughts, right? Like, I think that it's about reducing the stress, about reducing the anxiety, so that we can make a decision clearly, of course, with the information that we have right now. So, of course, that's self-compassion. But if there is stress around the decision and we find ourselves really anxious about it, definitely I would advise to seek professional help, because you want to make a decision in a calm state. You don't want to make a decision in a panic state. I tell my clients, don't react to things, act towards things. Like just, think about it, sit, if you want, use your wise mind, like Dr. Goyal was saying, but don't really use your emotional mind, because emotions leads to very, sometimes wrong decisions. We want to really think through such important decision. And of course, emotions can guide us, but if we act on them, they're not going to lead anywhere good. So I would say, if you're finding yourself struggling with anxiety around making a decision, definitely seek professional help, gather information, prepare yourself. You don't want to make a decision out of fear ever.
So we spend a great deal of time figuring out when the best time is to test someone, when do we test someone for the mutations? And I think in part we feel like it's important for people to have a little bit of time to learn about the diagnosis before they have to make a decision on risk-reducing surgery. So I think while it seems young sometimes for a 25-year-old to learn about their mutation, but this is when we start screening, and we don't really talk as much about risk-reducing surgeries. But I think, to your point, Dr. Loriola, it's really important to have that time. From a medical perspective, it's important to have the time, put a team together, finding a surgeon whom you like and trust, and feel like you have a good report. That takes time, as I guess, and then don't make a decision in a panic state. This is really important. And then I think another really important part is like, who do you ask for advice? It's like, a lot of people give you good advice, right? Or give you well-meaning advice, but this may not be the right advice for you. So I think being able to take the time and figuring out who to ask for advice, who's and reflecting this is really important. And at some point, I think I really like Dr. Goyal's approach. It's like, put yourself in the mind of this decision versus the other decision, because it will help you live with this, and then seek medical help, seek your friends' help for that. There's a couple of questions on the spouses. What is good advice for a spouse who's when a participant feels like the spouse is overwhelmed, they don't want to burden them? How do you have any good words of wisdom for that? Dr. Loriola, you deal with a lot of couples therapy and trauma therapy.
Yes.
How do you
Yes.
deal with relationship when you're already maximally stressed out?
Yes. Of course, we need to face that this is going to be a challenge for both, right? Like for both partners, for all family members. This is not going to be just the patient's, burden to carry. This is going to be a shared burden. Of course, it's going to be primarily impacting the patient, but we live in a society, we live in systems, we don't live alone, so the system is going to be impacted by the diagnosis, in a similar manner. The symptoms are the same. Maybe, of course, they might be more acute in the patient, but there is the relatives experience what they are experiencing as well, and they feel, when we are in a situation and someone is stressed, we get stressed, right? Like, because we communicate, our nervous system continuously communicate with one another. So if I'm dysregulated, my patient is going to get dysregulated too, because our system are constantly communicating through the vagus nerve. So we really need to attune, and of course we can definitely try to support each other, but you might also need help, and maybe just a safe space to talk. People, it's funny with my family. I work a lot on communication techniques, because we really don't know how to communicate with people. When there is a problem in the family, we want to fix it, okay? And we offer solutions. And that's the wrong way to go, because most of the time we just want to feel the feelings. We just want to talk to someone about our feelings and what's happening. We don't want solutions. We don't want magic. We just want to vent. And offering solutions is the wrong way, and the other person feels invalidated or misunderstood or alone. So we really, in the context of family therapy or couples therapy, you can both and all the family members can all feel supported, because there is someone seeing all of the emotions playing out and giving a, a, an environment where all can share what's happening for them, and fostering healthy communication, which almost none of us, without really working on communication, knows how to healthily communicate with one another in an effective manner. So I want to say that's the communication strategy is the most important piece in addressing stress, and the capacity to co-regulate, and accepting that there are going to be strong feelings in our loved ones too, and that's okay.
Thank you, Dr. Goyal. Anything to add?
In terms of supporting partners as they're navigating this, I think it's important for the partners themselves to get support if that feels like it would be helpful. I will say something like this can often has an opportunity to sort of bring couples closer together, but also we do see, unfortunately, that it can bring couples sort of further apart from each other. And so again, acknowledging that sometimes we talk about the medical diagnosis and if you're dealing with a cancer diagnosis, but even again, this type of diagnosis of the cancer risk, like it's the third person or the third partner in this relationship now, right? And so navigating that together, we find that sometimes we start isolating ourselves from our partner because we don't want to burden them, quote unquote. And what that actually does is create distance from your partner. And so trying to navigate how much you share, because often you're both thinking the same thing or maybe have the same fears and you're not sharing them with one another. And then you feel more lonely, right? And so you're sitting next to this person, they're having the same thoughts, but you're not sharing those with each other because you're trying to protect them. But in that sort of protection mode, you're actually creating distance. And so again, going back to Dr. L'Oreal's comment about communication and how that is important. But it is assessing, like, do you have the emotional space for us to talk about this? So maybe you don't jump right into it, but to say, like, I'd love to talk about this. Are you in a space where we can talk about some heavy topics, or can we find a time to do that? But also, setting aside quality time that is not medically related, right? So something that is just fun, or, how to be partner and partner together, like making sure you continue to incorporate that as you're navigating different medical decisions and appointments and, all of those things, making sure you still have that partner to partner connection of things that are not medically related, I think is really important for both the partner and also the patient.
Thank you, Dr. Kaplan. I may put you on the spot a little bit here, but what a question is a bit, do you feel like there's gender differences, how people cope with stress, or how people do better with communications? Are there something that you as a male would share that you have experienced that may be different?
And when you say gender differences, so you mean like in a relationship and that sort of thing about how,
I think it's like when you think there's a difference when males are stressed versus females are stressed, how the main manifestations are the different expressions patterns that as a female partner you may be more aware, and as a male partner you may be more aware of.
Yeah, I mean it's hard to generalize. It's very hard. I think that's maybe changed, our roles have changed over time as well. And so it's really hard for me to sort of depict sort of more of gender related. But I mean, obviously, and we've known for years, males were always brought up in a way to be very stoic about things. But I also think that can carry over to the female population as well. So yeah, I think it's quite variable. I mean, I think, there are definitely some cultural things that have come up. I think for male, that I do see, but again, I can't generalize. Like some men will feel like, oh, they've been the provider and that sort of thing. What happens if I no longer can do that? And I just sort of need to get through this. Whatever it is. Just because I've had patients that have different mutations and whatnot, and they have risk for various types of cancers, and to the point where they have so much anxiety that it worries them in their ability to be a provider in that way and to be functional in that way. So I think it is problematic. I think patients who can have the ability to express themselves in terms of their emotions. I mean, there's also different levels of what we call more, some patients, they just by nature tend to be more they intellectualize everything basically, right? And they don't allow time for their emotions. That's just how they're wired. And where some patients tend to be have more in touch with some emotional intelligence as well. So it's sort of navigating that as well. So it's hard for me to sort of generalize in terms of male versus female. I think in our current society as I see it, but definitely there are some pervasive traits that I think persist. I know that's not an exact answer, but that's just what I observe, because I think there are certain traits that do persist in society. They see between men and women and whatnot. So, yeah.
But I think this is exactly the answer we were hoping for. There's no generalizable response to trauma, right? Male or female. And I think I think everyone is a little bit different. I think it's important to meet your partner where they are on both sides, and there's no predictive patterns. And I think that's really important. And I think what both Dr. Goyal and Dr. Loyola have been saying is like, as the affected person, shape the narrative of what you want to be asked and what you want to talk about it. And sometimes that means you need to tell your partner when you don't want to talk. At the same time, as a partner, reach out to ask whether you can be helpful and what will be helpful, rather than providing reassurance. And I think what I see a lot is like our intense need to provide reassurance actually often comes across as minimizing someone else's trauma and distress. And I think that's an important pattern to be aware of, I think. So let's go a little bit. So we talked about ambivalence, we talked about the excessive stress. So what about denial? What about if someone is in denial? How do you deal with the denial? Do we have a good strategy for denial? What if someone knows they need to do something, but they just don't want to deal with it?
It's
Who
okay.
gets to that person the best?
I think it's okay. There are stages. I mean, see, a diagnosis like this comes with a loss, right? The loss of a regular life or a typical life, right? So denial and it comes with grief, right? We're losing something, and so denial is totally normal and healthy. I wouldn't try to change it. Of course the person is going to come it's going to come to realize that, that's happening eventually, but that's a regular stage of grief. I would just say, it's okay, if you don't want to deal with it now, it's okay. Of course, if 3 years from the diagnosis, the client still don't want to deal with it, that's a little different. But if they want to take a couple of months, I mean, let's say they're 25, they just got this diagnosis, they want to take a sabbatical of a few months to kind of like, whatever, let's pretend I don't have anything, it's okay, take your time, take the time you need. Of course, that this needs to be addressed at some point, but if that's what you need right now, that's fine, I think it's normal.
Thank you, Dr. Goyal.
Yeah, I don't have much to add beyond that. I think that's definitely, I mean, that word of grief is important that it's come up in terms of how we are conceptualizing this experience of, again, the loss of I appreciate the way Dr. L'Oreal expressed that. And but also, yeah, that loss of like what my future was going to look like and how I imagined it and now what it actually may look like. And so again, denial being a very common response. But I would say that if they're showing up for any medical appointments or if they're willing to talk to someone, that to me is a sign of maybe that, there's some room there. And I think somebody actually mentioned motivational interviewing within the chat. This is where that type of a technique, which is really around meeting a patient where they're at, right, it's a type of therapy where when somebody is ambivalent or in this state of denial, sort of recognizing just meeting them where they're at, right? Not trying to sort of like push the change, but maybe pointing out that ambivalence and working with it and rolling with it is important. But yeah, I think if they're there, if they're at the appointment, there's something there that's gotten there. So I wouldn't call it, I often will say it's not full denial, like it may be again avoidance, but something's there that's making them, there's a piece of them that recognizes something, they want to do something about it. The true denials are the people who never enter the medical system or, get an appointment and then never come back.
Yeah, Dr. Kaplan, anything, any good advice for what if you have a spouse who just doesn't want to do any of the recommended interventions? How do you deal with that?
Yeah, it's really difficult, and I agree with Dr. L'Oreal and Dr. Gold. It's very much a trauma response. When we look at trauma, avoidance, denial, that's sort of part of it's protective in a way. And so I think we have to honor that and looking this as anticipatory grief in terms of loss of part of my body, my function, my life, my relationships, that sort of thing. I think it's very important to look at it like that. I also think to look at it like a grief reaction too. Some people think of grief as being sort of a linear process. I'll just get over it or something like that. But I see it like more of a wave-like reaction. There's like an ebb and flow to that, and accepting that there is an ebb and flow to grief, and that just anticipating it, that's going to happen, and there could happen thereafter, whatever that intervention needs to be down the line. So I guess more acceptance of the grief and helping the partner as well in their own time, with that, and not because I think with having a partner that's overly supportive in that way that they want to be helpful, the way they do want to be helpful, I think that just it becomes problematic. It's invalidating. And I think working with the partner around their acceptance as well, because they're also dealing with their grief as well. And then they're going to sort of impose that potentially on their partner. So that's something to be aware of as well.
Thank you. So in the last 10 minutes or so, there's a lot of questions about like, when do you talk to your children about the potential that they have, that you may have cancer, that you're at risk for cancer, or that they may be at risk for cancer? How to best assess a child's maturity Any suggestion, any help there? I know this is the general question, but I think this is what a lot of folks struggling with. It's like, when do they tell the children?
I mean, I think the generic response to that is sort of that we want to be truthful with our kids to the extent that it's age appropriate. And I think, we don't want to create a relationship where there's a lack of trust from your children because they later find out information that maybe you didn't share. But that's sort of also in the context of we have to think about the specific child and the relationship with the parent and sort of what that has looked like and the other supports that may be around to do that. So there isn't sort of a one fits all answer. But I would say that we tend towards, at least my typical sort of general advice is sort of as much as you're able to be truthful and age appropriate with what you share. But again, there's caveats and there's a lot of it depends sort of there's like an asterisk to that. But that's sort of my general response to that.
Dr. Loriola?
This is a tough one. I mean, I don't work with kids or children or teens. That's why it's hard for me to give a response because there is a big difference between adults and children. They are in a developmental stage. So I don't know what would be best for someone in a developmental stage where their prefrontal cortex is not fully developed yet. Actually it develops up until we're 25 or 27. So I don't know if we want to wait that long. But I wanna say that it's, and there are kids that are very mature and can take the information, but my gut feeling would be, I don't know, maybe waiting until they're in their late teen years. I don't know. I mean, and they cannot do anything with that information probably up until they're adults. I don't know. So I don't know if I would tell them. Yeah, I don't know if I would tell them sooner than their late teens. I mean, I don't know why we should tell a 10-year-old, by the way, this is possible. Because, it's I don't recall if it's a 50-50. I believe it's a 50-50 for BRCA, right? Is that a 50-50?
True, yeah. Yeah.
So, I mean, it could be not the case, so it could be. So I don't know. I don't know, can you test them genetically before they're 18?
We don't recommend any testing before we actually have any interventions or any imaging studies for certain mutation where we start imaging studies or skin exam at a younger age. We may test sooner, but typically we don't. And I feel very, very strongly that any individual should be tested when they are ready and not when their parents are ready. I think it's really important that, because this is something once it's they cannot that you cannot unknow this, which is very important to understand. But what I think what's also important is as you said, is like when the kids are ready. So the kids often worry about the parents dying, right? So providing a lot of reassurance that if the patient is at risk for cancer, doesn't have cancer, that's communicated, right? That the kids don't sit in with this thought that the mom or dad are having cancer and are going to die and no one talks to them. And then I probably would submit to you that most kids are really noisy and they're nosy and they listen to you and they overhear your conversation. And so I think be truthful, be reassuring. So the kids don't listen into your bedroom conversation. Why do you think they don't know anything? They hear you worry about your cancer every night. And no one talks to them. I think that is very challenging as well. I think it's really important. Then the other thing that I always really, really worried about is like, if you don't tell your kids, but the neighbors do, or the neighbors' kids do, that does not feel very good. So I think it's like as much as you can be truthful. And I think as a mother and a father, you can provide probably the most reassurance and the most gentle way and appropriate way to communicate. But I think in your decision on communication, just weigh in what the kids may hear from neighbors, friend, or from an unintended conversation that I remember my parents always thought I knew nothing, but that was not true at all. It's like
Yeah, it's so true. Kids are really more intuitive than we give them credit for, or they can sense something is off, even if like, and so again, I'm not an expert with kids, but I think that is sort of the basis of that recommendation is often they do this sort of what's called magical thinking at times where they kind of create stories about things. And so if they feel something is off, they sometimes might even attribute it to themselves to say, like, am I doing something or what's going on? And so there is a lot of consideration that goes into such a topic, especially if you're considering like, is it the cancer diagnosis if you happen to have one? That I would say let's definitely share and be in a truthful way versus the mutation. I'm a mutation carrier, and you're not necessarily having day-to-day conversations about that. So there is nuance there. But yeah, I agree, Dr. Munster. There can be this unintended overheard. We want to be mindful of that, and that's where that truthfulness is so important.
I'd like to
okay, so
suggest, if I
go ahead, Beth.
one of the resources that can be really helpful for families are genetic counselors. Genetic counselors are trained to understand how to explain mutations to family members, whether they're adults or to talk about when to talk to their kids. So most people, their primary interaction with is a genetic counselors when they get tested. But the counselors are there for a lot of different conversations. So if somebody's struggling with their young adult children, trying to figure out if it's time to tell them, I would suggest trying to talk to a genetic counselor about it and see what they think.
Yeah, very good suggestion. Thank you, Beth. We have time for one question. Can motivational interviewing techniques help with decision paralysis? I think Dr. Goyal, you alluded to this a little bit.
Yeah, absolutely. So again, it's this sort of it's sort of a technique around ambivalence. I think originally it was created around like helping people with quitting smoking, or they were ambivalent about quitting and didn't like know how they wanted to navigate that. But I think now it sort of can be used in any context where we're looking at ambivalence around a decision, any kind of decision that you're trying to make, and seeing what stage of change, as we call it, are you at? Sort of, are you in a pre-contemplative stage where it's like you're not really thinking about it, or you're sort of starting to think about it? So something that can be helpful, especially when you're making a decision about surgery, for example.
Thank you. So we're coming off time. So if I may give all of you a couple of minutes to share closing thoughts. And Beth, I'm going to start with you.
When I see patients in clinic, one of the majority of the time we spend with patients who are actually talking about their mental and psychological health. It's all about decisions. It's all about telling other people. It's all about dealing with the stress associated with knowing that they have an increased risk. The stress of having a medical diagnosis that's not really a disease. It's a condition, but it isn't a disease. They're perfectly healthy. And it's very hard. And it's very isolating. And I just encourage everybody, try to find some sort of community where there's other people that you can talk to who share your experience. It's helpful not to be isolated, and it's helpful to share with people who have the same kind of concerns that you do. And it's not easy for everybody to be in like a group type of environment, but it can be, if you can kind of put yourself out there a little bit, it can be very helpful.
Thank you, Dr. Kaplan. Any closing comments?
Yeah, I think that's really important, Beth, to try to find your way of navigating through this once you understand there's this mutation sort of lingering over you, and that there is adaptive ways to move forth with your life and not feel so paralyzed with it. And I think being in a group of because there are peer supports as well. I know I have that with other patients. Be very helpful. People who have been dealing with this for years and years, and it depends. I think you have to find the right group of people. Maybe early on learning this, you have this mutation. So I think it's very important to have the appropriate group of peers as well, and to be able to avoid isolation. I think, and working on resilience in that way, whatever that means for the person. So, because I think we can build resilience, and sometimes we feel we don't have it, but it is there somewhere. We just have to learn how to access it.
Yeah, thank you for this. Dr. Goyal?
Yeah, I would say there is just no right or wrong way of navigating this. I mean, I think figuring out the ways that work for you, but I think the tell being sort of like, how distressed are you feeling? Like what's going on for you, and reaching out for those supports or those things that are going to help. But at the end of the day, there is no right or wrong way to kind of navigate through this.
Thank you. Dr. Loriola?
Yes, I echo all that was just said. I would just want to say, be kind with yourself. Reach out for help. There is a lot of help out there, free. Sometimes there is a fee for service, but there is also a lot of free support. Yeah, I'm happy to talk with Dr. Munster about free resources that are available to people that experience trauma and cancer. There is the Bay Area Cancer Connection I mentioned. But yeah, I mean, help is out there. Like there probably is a support group for you. There probably is a support group for your, family members. Just get the support. Like there is so much that you can get support for.
So thank you everybody for this wonderful webinar, and it's really incredibly helpful. I think what we can summarize is like, it is absolutely expected to be very stressed out. It is expected to feel ambivalent, to worry, to grieve, to fear. These are all normal responses. There is a lot of we can do about it, and most of all, you are not alone. I think that the part that's really important to take home is you're not alone. There are lots of people here to help, and I think please reach out. And I think with this, thank you very much. This is really incredible, your contributions, and I wish you a good evening.